Hemophilia is a bleeding disorder, and generally, or medically speaking, there are different ways of categorizing bleeding disorders. We have bleeding disorders that are associated with blood vessels. There are bleeding disorders that are associated with platelets, and the platelet is one of the cells that is necessary to assist in clotting. We have bleeding disorders associated with what we call coagulation factors. Others are associated with, an aspect that assists in breaking down clots. And so hemophilia happens to be associated with the coagulation factors. Our ability to clot or form a clot is heavily pegged on the X chromosome. So a man has an X and a Y chromosome, while a female has two X's. So if you got an abnormal X that is unable to produce the clotting factors, then you are likely to develop hemophilia. So hemophilia basically is commonly a congenital bleeding disorder, but you can also acquire it. So for you to acquire hemophilia, which I again did indicate is actually affecting a smaller percentage of bleeders, is associated with things we call danger signals. For example, if you go through a surgical process, or you have an underlying infection, or you have malignancies, if you have cancer, for example, the proteins that are produced by the malignant cells can mimic your clotting factors, to the extent that the body then produces antibodies against those proteins. In the process, those antibodies will target your clotting factors and start consuming your clotting factors. So that is one way you can actually acquire it. We've seen people who get exposed to infections, and the proteins from the infecting agent can also mimic your clotting factors, and by extension still produce antibodies that would subsequently cause a bleeding disorder. We also have people who have problems associated with the liver. If, for example, your liver is messed up, you have liver failure, your ability to produce these coagulation factors is lowered, if not impaired, and so you are unable to also clot. And we've seen patients with such presentations. So hemophilia can affect both populations, both gender, but the higher percentage tend to be men, by virtue of them having a single X, which, if abnormal, would then express itself as a bleed. In fact, majority of the times, it is a career woman, a woman who has one abnormal X and a normal X, passing the abnormal X to their sons. So actually, hemophilia is expressed in their sons, but in the daughters, the daughters will actually turn out to be carriers if they carried that abnormal X. So far from our database, I know previously we've been saying as a country we've reached about 600 patients out of an anticipated 4,300. But looking at our data, as we kept cleaning our data, we think this figure seems to have come further down. And we think we've only reached about 10% of our patients. We were happy at a point that we had reached 14%, but on a second look, we think we've only reached 10%. A person with hemophilia can have spontaneous bleeding. Nothing has triggered that bleed. Nothing has hurt you. You are just comfortably seated somewhere, doing nothing, and a bleed occurs. That tends to occur more based on the amount of the clotting factor in your system. And actually, it is on that basis that we classify hemophilia into three. We have mild hemophilia, where you have some factor, clotting factor within your system. Moderate hemophilia, again, there is some amount of factor but not as much. And then we have severe hemophilia, where there is almost no factor in your body. A lot of hemophiliacs tend to bleed even on some mild exertion. They are walking. When you have pressure put on the joints, they start bleeding. These are internal bleeds. When they get into contact with the hard surface or possibly hit themselves against the hard surface, you end up with a bump. If they injure the skin, they'll start oozing to the extent that the ooze never stops. So we lose patients because of this continuous, slow but sure bleed. Once we've determined through history that someone is potentially a bleeder, samples are taken and tested in a laboratory. And that would be able to tell us that this patient does not just have a factor deficiency, but it can also tell us the amount of factor that is missing so that we can classify that patient. So the tests or the sites that have capacity to provide the testing is Kenyatta National Hospital, Moi Teaching and Referral Hospital, and a bit in Coast General Hospital. The challenge in some of these smaller facilities is that the counties are not providing reagents for testing, but we have actually developed capacity for testing. So once we've actually determined that someone is a bleeder, we then prepare and plan them for treatment. We have various modalities of treatment. We have what we call on-demand treatment. It simply means you are bleeding, you need treatment. So we put you on some amount of factor concentrates. We also have a type of treatment we call prophylaxis. To prophylax basically is just to prevent a bleed. You don't necessarily have to be bleeding. We also have another one we call home therapy. Home therapy basically means that the moment you feel, there's a feeling patients have, we call it an aura. The moment they have that feel that something is about to happen, they infuse themselves. So as a country, we've done relatively well in terms of creating sensitization, making people aware of the disease. But we still have a large cohort out there that has not been reached. And the reason is that people have kept children away. When you have deformities in our societies, people tend to put you away from the rest of the society. So yet this is a condition that can be managed. So one problem that we have is that we've not reached the rest of the patients because they are either out there, untested, mislabeled, and kept off. The second thing is that the treatment for hemophilia is not a cheap mode of treatment. These are patients that I said can bleed anytime. These are patients that complicate. So we should be in a position as a country to intervene. Unfortunately, we don't have medications through our normal systems that have been used nationally to provide care. Our patients are heavy beneficiaries of donations. Now, it's almost impossible and unsustainable to survive and benefit on donation. For us as a country to move forward, the Kenyan government needs to get involved directly and procure for patients, because a single dose of a drug costs about 50,000, a single dose, and that can only be used for a child. An adult would need between 3 to 4 of those, and you want to treat this bleed for at least 3 days for it to come down. So we are basically talking about a disease that is not just directly debilitating, but financially crippling. So unless this process is supported by the government, it is almost an impossible disease to manage.